just give your name and just talk about where you're at right now, where you're at, what kind of work you're doing, just kind of up-to-date summary type of thing. That'd be good. So you can go in 3, 2, 1.
My name is Yusuf Yazici, and I'm a rheumatologist at the NYU Hospital for Joint Diseases in New York. I divide my time between seeing patients and also running the clinical trials related to rheumatoid arthritis and vasculitis, especially Burgess Syndrome at New York University. And we've been involved with all levels of and kinds of different clinical trials, patient-reported outcomes related, registry-related, industry-sponsored, and investigator-initiated clinical trials looking at both treatment, long-term outcome, and patient outcomes.
Okay. And by the way, you can look at the camera. That's
okay.
Fine. You're doing fine. Yeah, let's talk about, I always like to ask rheumatologists why you got involved in this particular field. Some interesting story about that.
One of the main reasons probably why I got involved in rheumatology and also Behçet is my father is also a rheumatologist in Turkey and has done a lot of work with Behçet. And we've been working with him over the years in both when I was training, I trained where he was, and then also continued our relationship through clinical trials and other investigations that we did, not just in Behçet, but also other areas in rheumatology.
And talk a little bit about, let me help you pronounce this, Behçet?
Yes, yeah.
Okay. I know I spelled it wrong, I'll try to say it right.
That's all right.
Just talk a little bit about what it is and some of the unique qualities it has apart from some of the other vascular diseases.
Yeah. Burgess syndrome is a systemic vasculitis. It's grouped under the vasculitic conditions that presents with most commonly oral ulcers, genital ulcers, various skin lesions, inflammation in the eye, and also at least some of the patients with inflammation in the gastrointestinal system. Most patients also have non-deforming arthritis, so that's why one of the reasons why rheumatologists see these patients. It has a unique geographic distribution in that it's more commonly seen in patients from the Mediterranean area, especially Greece, Turkey, Israel, Middle East, North Africa, Far East, Korea, Japan, and China. It also happens that these areas were along the path called the Silk Route, and it's sometimes referred to as the Silk Route disease because these populations over the centuries maybe possibly spread out the disease over the same geography. It's also different than some of the other rheumatologic and vascular conditions in that males are more commonly and more severely affected than females. And they tend to get their disease in the 3rd and the 4th decade in life. So the most severe patient usually is a young male patient. And however, in our experience in the US, we tend to see more female patients, but in centers around the Mediterranean, males seem to be a little more common, definitely more severe.
And in terms of treatment for it, is it a lot of the treatments that's done for the other vascular diseases or some special adherences do you have for this one?
The treatment of Burgess syndrome it really depends on what symptoms the patients are presenting with. An interesting aspect of the disease is that the natural course of the disease is one of waxing and waning, and in about 2/3 of the patients getting better over time with treatment and time. So keeping that in mind, we're usually very aggressive with treatment early on, knowing that we have an opportunity to turn off the inflammation and basically get rid of the disease in many patients. That doesn't happen in everybody, of course, but we have to give each patient that opportunity to hopefully respond to treatment. And the main cutoff when we're using different medications and making treatment decisions is that if the patients have eye disease or not, or if they have any systemic involvement or not. The patient, the most common patient that only has mucocutaneous involvement, so oral ulcers, genital ulcers, various skin lesions, can be treated with mild medications like colchicine, hydroxychloroquine, low-dose prednisone, or even topical treatments. And with managing those symptoms, they tend to get better over time, and they use less and less medication. However, if the patient has eye disease or other systemic organ involvement, then we have to start with the immunosuppressive drugs, either alone or in combination with steroids, and sometimes even combining 2 or more immunosuppressive drugs. Those patients also tend to control their disease and get off the medications, but it usually takes longer, up to 5 years and more, until we can get the disease really under control and feel confident enough to take off the medications.
What kind of breakout do you see between those that get the, the systemic versus the non-systemic? How does that break? I mean, are there more of one kind or the other?
No. If you look at the frequency of various manifestations of the disease, over 90% get oral ulcers, over 80% of patients get genital ulcers and skin lesions, about half the patients get eye disease. But if you look at only the males, that number goes up to about 70% of young male patients especially, who get inflammatory eye disease. The good thing with eye disease is that it is usually present at the beginning of the disease. It will be rare to get new eye disease after 5 years, so we can gauge how severe the disease is going to be within the first years of manifestation starting. Vascular involvement, inflammation of the blood vessels leading to either aneurysms or blood clots, can also be seen, along with central nervous system involvement, which are the most serious and hard to treat, but they're usually seen less than 10 to 15% of patients.
And talk a little bit about the clustering. We talked about that earlier, but tell me about the significance of that.
One of the reasons we prefer calling the disease Burgess Syndrome rather than Burgess disease is that there seems to be different pathways and pathogenetic mechanisms for different manifestations of the disease. There have been analyses done which are called cluster analysis, looking at different symptoms of the disease and to see if certain symptoms go with others. It's been shown that skin involvement and arthritis tends to go together, oral and genital ulcers go together, and blood clots and other pulmonary vasculature problems, aneurysms and things like that also tend to go together. So if we see one, then we usually look for the other, especially in the case of a patient that has a blood clot in their legs, and then they would tend to have more pulmonary aneurysm, which is the most common reason for mortality in Behçet's. So we would do a CT scan or other examinations to make sure that they don't have one that's slowly evolving.
And is Behçet's, I know there's a systemic, but is it typically fatal? I mean, or untypically fatal? What's the prognosis on that?
As I mentioned, most patients with time and treatment tend to do well with Behçet's. So it's very different than other, not just vascular conditions, but other rheumatologic conditions, that it's not really a fatal disease. It responds well to treatment, not in everybody, but 2/3 of patients have a very good chance of leading normal lives without medications after enough time on treatment. Mortality, when seen, is mostly reserved for young male patients who present with eye disease and other systemic inflammatory conditions.
And I had a Behçet's patient ask me this, in terms of the, I guess, the genital manifestation, you know, and the ulcers and that stuff. Sometimes it's put on their record and as, you know, a sexually transmitted thing as opposed to being related to a disease. Do you have any thoughts on that? I mean, that must also be difficult for some young people that are exhibiting these symptoms. Is that a challenge? Yeah.
One of the challenges that the patients have with Behçet's, given that they get skin manifestations like acne, oral ulcerations, genital ulcerations, is the worry that this might be contagious. However, Behçet's is not a contagious or an infectious disease. You didn't really get it from anybody and you can't give it to anybody. It's an inflammatory condition, body's own cells turning on certain tissues in the body. And that's why we usually use immunosuppressive medications to kind of calm down those cells until the overactivity is done. But it's not a contagious disease and patients should not worry about that.
Okay. And last question, a newly diagnosed patient, what would be some of the things you would say to them that they can help in their outcome, a positive outcome of this? What are some of the things that are high priority?
For a newly diagnosed patient, the most important thing to remember is that most patients with treatment and time will do well. So knowing that, I think, is a big advantage, that you have a clear goal and a time frame where your doctor can review the medications they're going to use, what the expected outcomes are at 1 year, 2 years, and 5 years. And if you're not meeting those outcomes, then treatment can be modified. It's important to make sure that there is no, even if the patient doesn't have any symptoms, there is a full eye exam that's done to make sure there is no mild inflammation in the eye, because if there is eye inflammation, the treatment changes for those patients who don't have eye inflammation. They can both be treated, both types of Behçet's can be treated, but it's just different medications, so we need to establish that. As we're giving immunosuppressive drugs, It's important to follow up with the doctor, follow up with the required blood tests and other testing that might be needed throughout the course of the disease.
That's a wrap.